So I guess we are online. Can you confirm me from the control room?
Yes, you're online.
Okay, so just on time, it's 2 minutes past 3 p.m. So good afternoon to all of you. And so my name is Alessandro Anselmo. I'm an HPB, and I would say liver and kidney transplant surgeon here in the University of Tor Vergata in Rome. And it's a great privilege for me to welcome all of you to this webinar. The topic of today will be the surgical treatment of colorectal liver metastasis. So first of all, I want to introduce my co-moderator. So please, Benedetto, if you want to say something.
Thanks, Alessandro. First of all, thanks to Professor Anselmo and Tisone to invite me and to organize such great masterclass, and of course to all who are participating. They are right now as discussant, and also, of course, all the audience. I'm here with such humility and respect among such great really surgeons. There are this floor person from whom really I learned some years ago what type of surgeon I want to be. So really thanks to everyone, and Alessandro, I think that we can start.
Thank you, Benedetto. So you're from Barcelona. So as you can see, we named these meetings like Italy versus Spain, not against, like someone said before, but like a friend. So the idea came to us in July. So we were just eating fish and drinking something in Barcelona when I came to meet you. So the idea was to create just a meeting between colleagues and friends. Short meeting because we are online, so we will be focused on be short. So it's 2-hour meeting, but very well focused on a single topic. And the topic of today, as I said, is the treatment of colorectal liver metastasis. So this is the first of our meeting, and I hope we can do some more. And we already planned 2 more meetings that will come in the next year. One on so if you can send the brochure from the control room, I'll show you just the brochure of the next events. So many more friends will be involved in this, and the first one will be on 18th of February, and the topic will be hepatocellular carcinoma, one of the main topic in HPB surgery. And the next one is scheduled for the 4th of April, 11th of April, and will be focused on the treatment of cholangiocellular carcinoma. So this will be the future. For today, we will talk about colorectal liver metastasis. And I think why we choose this topic, I asked myself and I answered it. So if you can just send from the control room the first 2 slides, just to explain why we choose this topic, is because it's an evolving topic, and there is no consensus on how to treat these patients. So if I can have the 2 slides, I will show you that there is no agreement between the surgical community on how to treat these patients. So it will be very interesting to understand all the speakers. So it has been said that it's like the throw of the dice. So okay, you can go further to the next slide, because I guess you all know and read this paper. So a throw of the dice because there is no agreement. So they tried in this paper, they tried to submit to very expert surgeon 10 cases, and the disagreement was huge. So there is no agreement also among very expert surgeons on how to treat this patient. So we will have 5 excellent presenters, and I guess we decide to do the discussion at the end. So I will introduce the speakers, then we will do a discussion with the ground, and we have many discussants. So I want to welcome them, all the discussants, and it's now my honor and privilege to introduce Professor Tisone. that is the chair of the hepatobiliary unit here in Tor Vergata University in Rome. Is full professor of surgery. He's also a great researcher, especially in the field of immunosuppression, and is very famous opinion leader all over the world. He's also very famous because he's been my chief since maybe 30 years, so it's with great pleasure. And I thank him for the inspiration and the mentorship. So I give him the microphone for the introduction. Professor Tisone, please.
Thank you very much. Thank you, Alessandro. Thank you, Benedetto. It's nice to see both of you, because I was just thinking before that both of you were my residents in general surgery a long time ago now. So I'm very pleased to see both of you working well and doing well. You know, when they start asking you to be the president, means that you are ready for retirement. That's why I'm now concentrating on golf more than surgery anymore. But anyway, I'm very pleased to have all of you. The session looks interesting, and the speakers are first-class people in the field. So I don't want to take a long time, or to steal a long time to the session, which will be, I'm sure, on time, very exciting, and I'm really looking forward to hear what you're going to say. So thank you for all of you for coming, and please start.
We will soon, Professor. Thank you for your welcome address, and so let me thank our sponsor that made it possible. So I want to thank Baxter for supporting us, giving us the chance to organize this interesting meeting. So we had, as I told you before, we had more than 500 subscriptions. So I will keep you updated on how many people are connected online. So we will start with the first presentation now, and it's my pleasure to introduce Professor Guido Torsilli, that is head of the liver surgery department of the Humanitas Research Hospital in Milan. What I can say is that when I met him the first time, I told him that he's a bad surgeon, so he can see with the ultrasound more than we can see with our eyes, and I learned from him a lot of things, especially some terms that are upper transversal hepatectomies, liver tunneling, mini hepatectomies. Recently, I heard something about the cluster, and then I learned that a parenchymal sparing hepatectomy can be a major hepatectomy, because we always think that is a minor hepatectomy, but can be very technically challenging. So please, Guido, and he will talk about the parenchymal sparing liver surgery.
Thank you very much. Thank you very much for the invitation at the meeting. I'm sharing the screen. Can you see it? And then I start. Thank you very much, Alessandro, for the kind invitation, to Professor Tisone too, and big hug to all my friends from Spain and Italy. And it's my pleasure. You know, you were too generous in presenting me, but anyhow, I will try not to disappoint your expectancies and the expectancies of the people that are joining this event. That it sounds quite impressive. So you assigned to me the talk about parenchymal sparing open hepatectomy and about colorectal liver mets. I have no disclosure. This is a case of multiple bilobar colorectal liver mets scattered everywhere, at least at this slice of the CT. And the question is if we can imagine surgery for a patient like this one. Even after chemo, the patient has a response with disappearance of some lesions, but anyhow, the results were more or less in terms of surgical feasibility equal to the pre-chemo condition. And if we look at the possibility offered by the standard surgery, classical approach to the liver, possibly liver anatomy, we have to ask to ourselves if an organ like the liver can offer just this solution, rather than offering, as Anselmo already told, the possibility to foresee different approaches and possibly infinite new kind of operation, taking profit of the complexity of the organ, to face with the complexity of the disease that are affecting the liver. Let's see. Well, the strategy dealing with the anatomy of the organ is based on 4 steps. One is the definition, pre-operative definition of the strategy. And nowadays we take profit of the 3D cast, pre-operatively obtained based on the pre-operative imaging. And this is better disclosed in tailoring the patient liver anatomy, and it's also facilitating for the younger the comprehension of the procedure that we are gonna doing in the patient that have been submitted to our attention. This is the cast of the patient that you saw before, after chemo. In green, the lesion, and in pink, those disappeared. And with the 3D cast, we measure the cluster, the volume, we define the cluster, and we define also the compass point. What do we mean for, of course, the volume is the future liver remnant that we are expecting nowadays. With the 3D cast, we can also foresee the remnant liver volume after complex dissection of the organ in a 3-dimensional, several planes are mixed up in a dissection. And before, it was quite difficult to really have an estimation of the post-operative liver, future liver remnant. Nowadays, the approximation is quite good, quite adequate, as it was published on HPB. The other aspect is fundamental for facing with this complex disease and taking profit exactly of the complexity of the organ is the definition of the cluster. And for cluster, we consider the group of lesions that can stay in one single resection area. And if we can identify some group of lesions, the resectability is possibly more or less possible. In this patient, we can identify 3 clusters, and the other 3 lesions are single lesion scattered elsewhere. Then, having identified this aspect, and finally identifying the compass points, what do you mean for compass point? Compass point are those lesions that are, I mean, like are the marginal part of the resection area of the cluster, the deepest one, especially if in contact with the major vessel, and the other. If we include this compass point, we are sure to remove all the lesions that are included in that cluster of lesions. Then cluster and compass point are fundamental to draw, ideally, a resection area, which is the one that we were planning for that patient. The surgical oncology is the other aspect, as it was, I said several times. The cornerstone in this sense is the R1 vascular. So the introduction of a new concept of radicality, which is the R1 vascular, that it works for CLM, colorectal liver mets, and ACC, because in this condition, the local recurrence risk is similar to R0. Then in this patient, we have the possibility to detach the tumor from the Glisonian pedicle, but moreover to with the hepatic vein, because the hepatic vein provide a further possibility. One is the amputation of the hepatic vein, which is not a possibility. The other is the full detachment, and in the middle is the detachment with partial resection, which cannot be the case of the Grisonian period. The adjustments that offered by the anatomy for those conditions in which we have to anyhow amputate sacrifice an hepatic vein is provided by the organ itself, and with the ultrasound and the preoperative imaging and the knowledge of that, we can find an alternative solution. Here is a tumor which is occupying the segment 8, the segment 1 paracaval, and the segment 4 superior, and the middle hepatic vein is embedded. In this condition, we have demonstrated that in almost all of them, especially if the preoperative image is showing a enhancement which is regular compared to the other part of the organ, means that even though you don't detect them preoperatively, there are for sure communicating veins. So veins that connect the infiltrated one and obstructed, like in this case, with the adjacent, like with the right hepatic vein in this case, and then you can provide, this is a liver tunnel with detachment from the right, from the left, and the resection of the middle hepatic vein. The last aspect is the guidance. The guidance, of course, the guidance is based essentially on the queen of the guidance, which is the ultrasound, which make transparent the organ and permit to identify the structures and take profit of the structures rather than coming far away from them, challenging the dissection in a 3D manner, which are quite complex. The fingers, we are talking about the open surgery in this condition, and the fingers are posterior laminal, together with the ultrasound, the mobilization. The hand is behind the liver, above, in front of the inferior vena cava, and then the possibility of the surgeon is to identify the finger, the electrocautery, the vessel that he has to pass through, and then drawing in his mind the dissection. With this exploration, he devised the resection area. And once proceed in the operation, the other aspect that is helping the surgeon for guiding this dissection are the vessels. So challenging the anatomy from the surface. A major vessel as the hepatic, like in this case, the middle hepatic vein is already detectable in its peripheral branch just behind the surface. This is the middle hepatic vein branch, led us to expose the middle hepatic vein. In this case, we had to resect, and we resect the middle hepatic vein. And what we found, just below, we will find the left portal vein. The left portal vein drives us to the dorsal part of the P58. In this case, we had to resect segment 8. And it opens the angle between P67, P58, and the right hepatic vein. And at the end, the dissection is completed and the liver tunnel is accomplished. The results of this approach is a restriction of major hepatectomy. Parenchyma sparing rejection are the vast majority, while in complex condition is exceptional to need a major hepatectomy. Here is a case in which there are two big clusters, because the regions are almost scattered everywhere. We identify the compass point. The dissection is drawn in a fusion imaging in this case. And then we proceed with the surgery, a roller coaster with removal of 83 lesions. It's a safe complexity. We have compare the results of the complex core hepatectomy and complex limited resection in this multicentric study compared to the reference standard of represented by the right hepatectomy, and they perform better than the right hepatectomy for severe morbidity and liver failure, except the complex core, with they having a higher rate of bile-leak. But the complex core, so in like the tunnel, nowadays with the air leak, we have dramatically reduced this occurrence. This is a series of multiple bilobar 9 was the median, 4 to 83 the range, 9.6% the number of major hepatectomy. The majority just left the hepatectomy. 0.1% is the 90-day mortality. 42% had more than 10 lesions, and 35% were bilateral. So possibly should be considered otherwise unresectable. The bilateral lesion behave in terms of overall survival not significantly worse than the R1 vascular singular or R0. And this kind of surgery offer you in this patient, in example, we removed 36 lesions in a single operation. The patient after 1 year had the relapse, had 10 lesions, and we could remove all of them. And it's of note of 131 patients with the liver-only liver resection, 62% were resected. Means that keeping the skeleton means more salvageability, even though it's a complex presentation. In relation with the tradition, I mean the two-stage hepatectomy and the ALPS, for the two-stage we challenged the Colbrus, and this was showing that overall survival in intention to treat is better for the one stage because we do not have dropout, and moreover the recurrence-free survival is quite similar. So the two-stage is not selecting the best patient. And with the ALPS, we were challenged by the Italian registry. The matching was possible only 1 to 2 because the database of the ALPS could not achieve the complexity that we demanded. And the results were, in terms of long-term, similar. In terms of mortality, of course, it was much lower for the R1 vascular. And in terms of major contact, we must say that we had a more complex presentation than the other series. Then the challenging goes in favor of this approach. Reproducibility. This is the number of operations done by my staff, more than 50%. So it is possible in approximately 5 years to lead to this kind of performance where we are. We conclude with the patient that we have shown initially. This was the cast. This was the other representation of the foreseen operation. These are the dissection area. This is the detachment of one compass point behind the middle hepatic vein with partial resection of the vein. And this is the resection at the end, the dissection in a roller coaster fashion, detachment from the vein, and the removal of all the lesion. Where we are going, and going to conclude, we have followed a path that has been quite long in the years, disclosing the new kind of operation. And now we are, in the fact, exploring a new concept of liver surgery, detachment, roller coaster, a sort of parenchyma-sparing major hepatectomy, guided by the anatomy of the patient. Thank you very much for the attention.
Thank you so much, Guido, for your fantastic presentation. So if you can stay with us, I will ask Benedetto to present the next presenter.
Okay, again, thanks, Professor Torsilio, really very interesting talk. So we can go on with the next talk. Now is the turn of Spain. So Ruben Syria, let me introduce him. He is our worldwide well-known liver surgeon from Córdoba, I repeat, from Spain. He is really very well known as a very experienced minimal invasive liver surgeon. However, his talk right now is gonna be focused on the surgical management option for multiple bilobed colorectal liver mets, which is really an issue for all the surgeons, especially in this new era where we are living right now with new chemotherapy, where more patients shift to surgery, to resection, compared in the past. So, Ruben, the floor is yours.
Well, thank you very much. Thank you very much, Benedetto, for your invitation. Professor Anselmo, Professor Tisoni. It's a real honor and pleasure to be here with such an amazing expert of panel. So I will talk about the surgical options for the resection of multiple bilobar colorectal liver mets. I will try to stick to the 10 minutes time we have. So I think I like to recall this sentence from Howard, who said that the surgeon role is to provide adequate margin negative RC resection with a minimum of post-operative complication to ensure appropriate adjuvant therapy. This was said in 2006. And this is the traditional oncology, as was said, but in the oncology for colorectal liver mets, we have a huge amount of parameters which we have to deal with. And I tried to synthesize all of them in the mind of a surgeon. And I think that we as surgeons, when we talk about bilobar, multiple bilobar colorectal liver mets, we'll think about, will we have safe resection margins, or do I need them? Shall I do this without or with a colectomy? Shall I have a remnant, not ribbon remnant? Is it, as Professor Tosilli says, is it technically feasible, and is it oncologically feasible or appropriate? And of course, we had to discuss it with the patient. So I tried, and I really thought about this slide because it's going to be the main focus of my slide. I tried to synthesize all the options in one slide, and we will try to move through it all around my talk. So when we talk about bilobar colorectal liver mets, the patient will very likely go to chemo. And to my mind, my first question is at any chance will the patient become fully resectable? Professor Tosilli gave us a beautiful picture of what is resectable or not. But if I really think not, we can talk about hundreds of liver mets. Probably the option is the transplant. We have full graft transplant, rapid transplant. Our colleagues from Italy developed the heterotopic partial liver transplant. And these are the results from the Swedish groups. I want to go inside these results. I think Professor Mazzaferro will explain in detail. But definitely the liver transplant, I think that if some patient has a point, we are working on this with the Toronto team and the Navarra team. And definitely, if these are the standard indications, probably transplant for colorectal liver mets with well-selected patients will reach very, very optimal results. But if we think that the patient may become fully resectable, and I really put this intentionally, if I do not need maneuvers to increase the volume, I want to really support what Professor Tosilli said, is go straight to one-stage procedure. I won't go in depth with this because Professor Tosilli already said this, but I would remind that the first option is parenchymal sparing resection. Professor Tosilli did a beautiful talk about this. But if at any point we think that the patient is resectable, and if we think that we need to get maneuvers to increase the volume, I place this intentionally here because there are some patients which we have control with chemo, but we may need or may want to reinforce them with other strategies. That's why I place here hepatic artery infusion and radioembolization strategies, because I think they are good options, not only for fully unresectable patients, but also for patients in which we want to make some kind of downstaging. There are a couple of manuscripts which are quite interesting. This is one multicentric American study, and I'd like to recall your attention to this thing. Almost 10% of patients who were deemed unresectable were downstaged and received a curative liver resection. I don't know in Italy, but in Spain, the hepatic artery infusion programs implementation is very low. And everything that is quite a good new evidence that says that this strategy combined with resection may downstage some patients and may add some survival independent of the KRAS status. Also, I really think that, for example, that radioembolization brings the best of the two worlds, brings the best of the biological strategy, and also give us the possibility of hypertrophy or remnant liver volume. This is a manuscript from the group of Navarra, in which 9 cases were downstaged and a major laparoscopic liver resection was done. This is a real colorectal liver met, in which initially resectable was brought down to a major hepatectomy, and the results are pretty awesome. So going back to our schema, if we think that the patient is resectable, but we need maniobers to increase, and we have control with chemo, then we are moving to the two-stage procedures. I wrote here spaghetti adequate regeneration. I don't know if this is correct. My feeling, what I wanted to say is that if we think that liver is going to regenerate adequately or not, it depends on a lot of factors, but definitely we have two options. We had the classic two-stage procedure. We had the ALS procedure, in which it's similar to the stage, but with a resection. And we have learned from ALS that, of course, the increase of the volume is higher and time to regeneration is lower, and it's very likely that we achieve higher resection rates. I think that in the early times of ALS, we did not have experience, and the patient selection was probably not clear, especially with cholangios and those bad indications. But a recent trial, the LIGRO trial, has reported a survival advantage of ALS versus two-stage. I think that now this LIGRO trial is real, is reliable, and we should keep this in mind. But I would like to recall what Professor Dossili said, and I think this is a good, important paper from our Italian colleagues, which was published 2 years ago. And it's not only ALS versus two-stage vitectomies, which are most of the comparisons which are done nowadays, but also ALS with single-stage parenchymal sparing resection. I think this was a beautiful paper in which a match was a well-matched cohort, in which, of course, R0 resection was higher in ALS, but probably in this era of new therapy, new chemotherapy, and considered R1 vascular, ALPS, you have to pay a price for the ALPS, and you have overall more morbidity, more mortality, and probably in well-selected patients, you don't have improved survival. So this is my personal picture, and I want to bring some new players to the game. The first one is the genomics. I think that's this, because this picture is a very surgical picture. It's just an anatomical picture. But I think we should bring the genomics to our strategies, and I'm very happy that RAS mutation has been included in this sort of meta-triggered scoring for the colorectal liver mets. But there are some other players in the field. And VRAF V600E, I'd like to recall your attention for this manuscript. I had the pleasure to work with Shinko Bayashi in Japan. But this one, which was recently reported, you see that in patients with VRAF V600E mutation, who went straight forward to surgery because it was a solitary resectable case, it was exactly the same as if this was unresectable. So this is a very, very, very bad mutation. And also the second play in the game is centralization. This elegant paper from Vega and Conrad from Boston determined that from 72 patients deemed unresectable, a liver surgeon was able to rescue almost half of them, considered unresectable. And this recent paper also from Lancet put the focus on local multidisciplinary teams compared to specialty teams in which resectable patients were rise up from 25 to 75%. The third play in the field I'd like to recall is minimal invasive. I think we all know that minimal invasive is a good option for colorectal liver mets, but recent papers have studied bilobar liver mets. This one compared two-stage lap versus open hepatectomies, shows that it's feasible with less rate of complications. And this another manuscript from the same group, from our French colleagues, shows that laparoscopic parenchymal sparing hepatectomy versus laparoscopic major hepatectomy in a 82 versus 82 cohort population also was feasible, the parenchymal sparing laparoscopic hepatectomy. So these are all the players, but I'd like to recall the most important player is the patient. So we should bring individualized and patient-consented strategies. In this sense, I'd like to show you this video. I'm going to show you two cases. This is 12 or 13 liver mets patient. It was a pre-chemo situation, but the patient was a mutated RAS status. And after chemo, the patient was, the liver mets reduced, but we considered that well, the patient, the aggressiveness of the disease was high. We did not have enough volume to do a right hepatectomy. So we did a clearance of the left lobe, and we performed a tourniquet ALPS, which is a variation modification of ALPS. But I think we should all surgeons keep in mind, not only pure ALPS, but also less aggressive modifications. So it's quite easy. We did a pure hanging maneuver, which you are going to see here. After clearing the left lobe with a pure hanging, and then this hanging is placed with a tape, and this tape is tightened all around the canticle line. And you will see that after tightening the knot, here you will see that we will tighten the knot with a very, very small hepatotomy, and we will have a very, very similar effect. You see this ischemic transection line, but it's not a real transection line, it's a ischemic line. So it's a beautiful modification of the ALPS, which is fairly less aggressive and probably with better oncological results because we did not do any mobilization, any touch of the liver. So I think it's quite a good option. So the patient went very well. We ended up the right hepatectomy, and the patient is almost a year and a half now free of disease. So in this case, this is an individualized application of strategy. And I'm going to show you a similar case in which we have 23 liver mets, but this case was a wild type KRAS. The patient was a fatty patient, and after 1 year panitumumab, the patient underwent surgery. But we considered that this patient was a good patient for a parenchymal sparing strategy. So we brought the patient to a hybrid procedure with a full mobilization bilaparoscopic approach. And then we did all these resections. It was just one week after the COVID shutdown, and the patient had a full pathologic response. So two similar cases, but not exactly the same, underwent two different strategies, which I think that were fairly good. So I'm not going to give any conclusion. I'm just going to put my personal picture or the way I find, or the way I try to modestly resume or put a small schema of all the potential surgical options for the resection of multiple bilobar colorectal liver mets. Well, thank you very much. And again, it has been a real pleasure. Thank you very much.
Thanks to you, Ruben. Really very nice talk. And you're right, it's very difficult to make strong conclusions. You're right that we should tailor the treatment for every patient. The problem, the issue is that never more than ever. Now more than ever, we have so many options, strategies, which will make really very, very difficult the right decision for the right patients. So Alessandro, we can go on.
Yes, sure. I also want to congratulate Ruben, and he showed us that also the biology should be taken in consideration when we choose a strategy. And the next speaker, so it's a pleasure to introduce the next speaker. He's also a friend, but he's Professor Aldrighetti. He's the director of the HPB and General Surgery Division at San Raffaele Hospital in Milan. Of course, he's a pioneer in the field of minimally invasive surgery, and he's also the founder of the minimally invasive liver registry in Italy. And he will address the team strategy optimization in combined resection for the synchronous colorectal liver metastasis. That is a very nice topic. And so it's a pleasure. I give you the podium, Luca. Thank you for coming.
Thanks a lot, Alessandro, for your invitation, and thanks to Professor Tisone and to Benedetto. It's great to spend time with Spanish and Italian friends. So very nice to be with you. I'll try to share my screen. And I ask you if you see my presentation. Do you see it, please?
Yes, we see. Yes, we see.
Okay, so we already realized that colorectal liver mets are a large part of activity in any liver center. This is our experience in 16 years. We performed a little bit more than 3,500 liver resection, and almost 1,300 are for colorectal liver mets. So basically almost 40% of the resection are done for colorectal mets. And the picture of synchronous metastasis is pretty large, because 1/3 of resections are for synchronous colorectal mets, but you can see that indeed only 18% of them are combined resections. So this means that synchronous metastasis do not mean synchronous resection. So why a team strategy is so important? Well, obviously there are three areas. First, how much is important the multidisciplinary team experience, and I will quickly address this point. Then how much is important a team approach to optimize the colorectal and hepatic surgery. And finally, how the team is important to choose for the patient the best available surgical approach. As for the first point, now multidisciplinary approach look like a little bit like a slogan, but actually that's absolutely crucial. You can see here how much it can be crucial to avoid that the single surgeon decision take place. You can see this is a paper showing how large is the area where there is a disagreement of experienced surgeon in the management of colorectal liver metastasis. So that's why we needed to work together in a team group. And you can see here also a very nice paper. This is an Italian one, so that's why I'm pretty proud to show it. This is from the group of Professor Capussotti, so meaning now Professor Ferrero. And I think that's very important because it shows how large is the difference in terms of prognosis when the patient are managed by the very first beginning of the history in a single center, or at least they receive an early referral to a major center, and how worse is the prognosis when the patient is referred to a major center only in a late phase. So the multidisciplinary approach in a referral center is absolutely crucial to avoid not only wrong technical choices, but also to avoid worsening the diagnosis of the patient. Especially when we are talking about synchronous colorectal mets, discussion in the MDT session is very important. You can see here many possible scenarios where discussion is important. First, upfront surgery versus neoadjuvant chemotherapy. This is a very difficult issue in synchronous metastasis. Then combined surgery versus stage treatment. And finally, nowadays, we are also talking about liver versus colon first approach when a staged treatment is decided. As for the first point, you can see that not always the patient get a real benefit from receiving preoperative chemotherapy. So that's why it's very important to discuss about each patient. And here is an experience from our center together with the Brisgay group. And you can see how this was focused obviously on laparoscopic cases, but what is important is that in those patients with a very favorable biology, like a single lesion, less than 5 centimeters, negative normal nodal status of the primary tumor, low CA, and wild type KRAS, well, there is no benefit in receiving preoperative chemotherapy. So that's why it's absolutely important to discuss in a team group with the oncologist if there is the need to perform before surgery chemotherapy. And it's also absolutely crucial to have a team strategy, including the colorectal surgeon, to decide whether to take the patient to a simultaneous approach or to a staged approach or to a liver first approach. That's, I think, a very important paper on a very large series of patients, more than 7,000 cases from the liver mass survey registry. Is obviously a multi-institutional study that was run by Felice Giuliante and René Adam. And what you can see here is that the key point to decide whether to take the patient to a synchronous resection or a staged resection is basically the burden of the liver tumor. Because you can see here, obviously, when there is a solitary colorectal mets, if a minor or low risk hepatectomy is decided, simultaneous approach is the first choice approach, but also in multiple colorectal liver mets, if a minor or low risk hepatectomy is planned, again, simultaneous approach is the first choice approach. So team strategy means to discuss with the oncologist and means to discuss with the colorectal surgeon. And the relationship between the liver surgeon and the colorectal surgeon has to be addressed. Or better, is it necessary to have two teams to work on synchronous metastasis? Or if we have a well-experienced surgeon in both the liver and colorectal surgery, a single team is good enough. We did a study, a specific study on that with other important centers, Paris. This is the Brisgay group, Maggiore Hospital, so Professor Iovine, then San Raffaele and Sant'Orsola with Matteo Cescon. And we compared the results when a single team is performing both liver and colorectal surgery and those centers, like our center, where two teams are working sequentially on the same patient, meaning the liver surgeon and the colorectal surgeon. And what came from this study is basically that if you have a very experienced surgeon in both liver and colorectal surgery, there is no benefit in having two teams. You see, there is basically same results in terms of both overall survival and in terms of morbidity. So I think this is an important message. It's important that we consider dedicated surgeons, but we cannot forget that there are centers where an experienced surgeon is pretty able to perform both type of surgery. And even more, when there is a good experience, two teams or one team is not affecting the choice between open and laparoscopic surgery. When we look at those factors who are actually influencing the final choice, it's only the number of liver lesion that is pushing for a laparoscopic surgery or an open surgery. I think it's still a good and important point, in spite of very nice preliminary papers showing how much laparoscopic approach can be useful in multiple colorectal mets. Ruben showed a couple of them. Still, I don't think lap surgery is able to perform a very complex parenchyma sparing resection like Guido showed us before. What about the third point, that is which surgical approach? This is our experience in minimal invasive surgery, a little bit more than 1,500 resections, with a pretty good number of combined resection, lap, liver, and colon resection. And we know that minimal invasive surgery gives some advantages also for colorectal liver metastasis. And this is a systematic review and meta-analysis from Ruben showing that also in combined surgery, the laparoscopic approach can give advantages over open technique. Please, I want to remark it, we are talking about minimal invasive approach for colorectal mets, but keep in mind complexity of resection can be still an important issue for taking the patient to open surgery. What is interesting is that even when liver surgery is done by open, there is a benefit to perform colorectal resection by laparoscopic approach. And this, I think, can be something interesting also for those very complex liver resection in a combined situation. This is a paper from our group showing that indeed complications are lower in those cases resected by lap on the colon when liver is approached by open. And again, laparoscopic approach is probably giving some advantages, probably also in terms of oncological outcome by reducing the severity of complication. Again, you can see here when liver surgery is performed by lap and when liver surgery is performed by open approach. And this has been also demonstrated in a meta-analysis. This is a recent meta-analysis from 12 studies, more than 600 patients included, and you can see laparoscopic approach is giving advantages in terms of lower postoperative complication in simultaneous resection. I just want to present you. I will not enter in the details because unfortunately we don't have the time to do it, but if you want to look some recommendations about how to deal with minimal invasive approach in simultaneous resection, please take a look to our Italian consensus that was recently published, including all the Italian hepatobiliary and colorectal community. So at the end, team strategy is absolutely fundamental in management of patients with synchronous colorectal liver metastasis. The MDT discussion is the key point to define the indication and the timing of surgery and chemotherapy, improving both short and long-term outcome of patients. One indication to surgery has been defined and combined treatment has been chosen. The adoption of a one team versus two team approach is based on a single center policy and preference with no influence on outcome of choice of the approach. And finally, minimally invasive approach, both in colorectal and hepatic surgery, is able to give some advantages on postoperative outcomes, even if, again, I just want you to pay attention that there is an area of very complex resection where I still believe minimally invasive surgery has some difficulty to be applied. Thanks a lot for your attention and for inviting me.
Thank you, Luca. Thank you. It's always a pleasure to learn from you. You have the power to open my mind. At least for me, it's always a pleasure. And I start from your end. You found a very good balance between. I know you are a pioneer and a fan of minimally invasive surgery. So I appreciate that you found a very good balance between one and two team strategy and between the open and the minimally invasive approach. So I thank you for that, and I give the podium to Benedetto to introduce the next speaker.
Again, thanks, Professor Aldrighetti, for your talk. Very interesting. It's always very interesting to see the consensus, the Italian consensus. Maybe after this talk, after this meeting, we arrange some type of Italian-Spanish consensus in the future. I hope, hopefully. Well, let me introduce the next speaker, who is Santiago Lopez-Ben from Girona, which experience in minimally invasive surgery makes Spain at highest level of liver surgeon championship. It is possible to call like that. So Santi, you have the mic. You can start your presentation.
Okay, thank you very much, Benedetto, and thank you all of you for inviting me. I have pre-recorded the speech, so we can speak after that.
Perfect. We can start.
Good afternoon. I'm Santiago Lopez-Ben.
You're perfect.
Yeah, we can hear it.
Firstly, I would like to thank all the organizers for inviting me to speak about the liver-first approach in the treatment of synchronous colorectal liver metastases. So we know from several years ago that the only potentially curative treatment for synchronous colorectal liver metastases is to resect both the primary and the liver tumors. Given the fact that if we only reset one of them, the results are similar to those that only receive chemotherapy. So we have mainly three strategies. The first is the classical one. We reset the primary, then chemo and liver resection. We can reset primary and liver in the same operation in a simultaneous way. And finally, we can resect first the liver tumors and then after chemo resect the primary. This last option was firstly described by the group of Gilles Mentin in 2006, and they showed the results of 16 patients with a high burden of liver disease, and the results, the short-term results, was very impressive. Since then, several papers deal with this topic, and I would like to comment a couple of them. First, this study taken from the database of LiverMed Survey, completing almost 800 patients, mainly underwent the classical approach with colorectal resection first, and we have to take into account that there was more rectal cancer and less nodal involvement in the reverse approach group. After the analysis, either if we take the time of diagnosis or the time of the last surgery, there was no differences in terms of overall survival or disease-free survival between both groups. 2018, there was this other study with 650 patients taken from a collaborative French group. Again, most of patients was underwent classical approach, and as in the last study, there was more rectal cancer, more nodal involvement, and more liver metastasis in the reverse approach group. Before matching, there was a slight tendency to better disease-free survival in the classical approach group, but after matching the patients, these differences disappear. And the authors conclude that both classical and liver-first approach strategies should be proposed to different patients. And I think this is a very important concept. In the last year, this meta-analysis was published, including both the previous both studies and others, and the result was almost the same. There is no differences in terms of overall survival or disease-free survival between both groups, and the authors conclude that both approaches are feasible and safe, and that we need randomized control trials in order to further evaluate their outcomes. But in my point of view, we are mixing here sheep and goats. And even more, we are trying to put against one to the other. And I think it's not the correct way to see this topic. I would like to comment this recent study of this year, taking again from a database of liver met survey, but in this case with more than 7,000 patients. And this patient underwent the three ways of approaching these patients, with primary first, liver first, or simultaneous resection. Again, the classical approach was applied to most of patients, but in this study, there were three scenarios. The first one with a patient with only one lesion. The other group was patient with multiple lesions, but confined to only one lobe. And the third group was that patient with multiple and bilateral liver metastases. Again, in the liver first approach, there were more rectal cancer, there was higher liver tumor burden, and there was less nodal involvement and received more radiotherapy. In this, with all this data, there was two separate propensity score analysis undertaken between patients in the liver first against patients with primary first, and between patients between liver first approach against patients in simultaneous resection group. If we analyze the group with solitary metastasis, we see that there is no differences in the whole population and in both propensity scored analysis between liver first and primary first, or liver first and simultaneous resection. The same results can be seen in the group of unilateral multiple disease, with no differences in the whole population or in the two propensity score analysis. But in the group of bilateral lesions, there was a better overall survival and disease-free survival in the liver first approach group. If we analyze this group of bilateral colorectal metastases, we see that in the multivariate analysis that only the surgical strategy using liver first and to achieve an RO resection was a risk factor for overall survival. And in fact, the authors propose an algorithm for the treatment of these patients in the cases of solitary or unilateral they propose simultaneous approach in low-risk patients and a staged approach in high-risk patients, given the fact that that simultaneous approach have a tendency to more morbidity after the resection. And in the case of bilateral lesions, they propose a liver-first approach. I would like to comment on a special case where we think that is especially indicated to perform a liver-first approach, and that is the case of patient with a high-grade rectal cancer, more than T3 or N positive. That is the group that should be treated with radiotherapy as well. And these patients, we use the interval between radiotherapy and the rectal resection to perform the liver resection. In this group of patients, we can see that more patients in the interval group can achieve resection on both sides, and the duration of the whole treatment, combining chemotherapy and both surgeries, can be reduced by this approach, with no differences in terms of overall survival. As a conclusion, we can see that all three strategies are efficient in simultaneous colorectal liver metastasis, and liver-first approach seems to fit better in cases of bilateral colorectal metastasis. And I think that we can be friends and not be a fight between both strategies. Thank you very much.
Always friends, Santi. You are right. You're completely right. We are a group of friends right now. And Alessandro, do you mind to introduce the next? And
yeah, we left one big for so last but not the least, it's my pleasure to introduce Professor Vincenzo Mazzaferro, that is the full professor in Milan at the National Cancer Institute, and is I would say an opinion leader worldwide, recognized on oncological indication for liver transplantation. So I gave him this topic. So the title is liver transplantation for colorectal liver metastasis. Is it today or near future? So Professor, I give you the podium for your presentation. Thank you.
Okay, thank you very much, Alessandro. Thank you, Benedetto, and all the friends from Spain and all the other people connected. So let's see if I can share the screen. All right, okay. Sorry, I'm trying to wait till this disappears. Okay. Okay, can you see the screen?
Yes, we can, but it's not full screen now.
It's the presentation mode. You have to shift to the normal mode.
Okay, now let me see. What about now?
Yeah, that's fine. That's fine.
Okay. So thank you very much. We are discussing on liver transplant in the future of treatment of this disease, which is kind of a difficult issue. Now, the future, I think it depends upon our choices, and depends on the result of our studies, and depends also on the, I would say, epidemiology of the disease we are discussing, and also on the predicted transplant activities in overall in Europe. So the future is somehow in our hands, but also is in the hands of the disease. We should consider that the cancer burden for colorectal cancer in Europe is huge. It is the second most common cancer 520,000 cases in 2020, 250,000 deaths, which represented 12.6% of mortality of the whole European population. And if you think that about 50% of patients with colorectal cancer have at some point of their history liver metastasis, you can see that the number of patients with this disease is truly huge. So when we look at the indication to liver transplant for this disease, for colorectal cancer, we may see that this represents between 1 to 2% of the actual patient with the colorectal cancer. But even though 1-2% of 520,000, half of them with colorectal liver mets, it represents something in between 2,500 to 5,000 patients per year to be considered, let's say, for liver transplantation in case of liver metastasis. And this is a number that is able to saturate the whole liver transplant list in any place, maybe with the exception of Spain, considering the tremendous donor rate that they have. But apart from Spain, the rest of the world will be unable to face this condition. A condition that is been already organized, as you can see here, with some restriction, and going over and over, we found more and more restriction because, as I said, the selection of this patient is in fact a necessity. It's not only an option. Okay, next. Let me see. Okay. Now, with respect to the background we have with this indication, we have no time to go into details. We have a lot of literature, and some of the speakers have already presented some results. I just like to point out one single study that was produced by one of the many studies done from the Oslo group, which has owns the largest experience on this indication. And the study is important because it compares what we have to compare. When we have a patient with unresectable liver metastasis, the other option, apart from transplantation, is chemotherapy. If we decide that this patient is unresectable, no other option with respect to chemotherapy we can present. And in this study, they compare the result of a first series of liver transplant for colorectal unresectable liver mets with chemotherapy. Chemotherapy, according to this study, Nordic 7, done in 2015. In this trial result, there are two important results. First, there is a clear increase in survival in patients receiving liver transplant in comparison to patients receiving chemotherapy, again, for unresectable liver-only metastasis. And that is a huge difference from 56% to less than 10%. But what is even more important is on the right-hand side of this cartoon, which is the equal recurrence-free, let's say progression-free survival in these two populations, which is extremely interesting because among the two populations, the liver progression in chemotherapy-treated patients leads to death, as you can see from the recurrence to the left side survival. In comparison to the recurrence after liver transplant, which is mainly a pulmonary recurrence met, which are often resectable and for this reason curable somehow, at the point that even though you have a similar progression-free survival, similar recurrence rate, the survival, the long-term survival of the liver transplant population is much better. So this is extremely important, and in my view, because pulmonary progression after liver transplant seems very different from liver progression in non-transplant patients undergoing any kind of medical treatment. So as I said, patient selection is a necessity because you know, the numbers are incompatible with the number of patients. The number of transplants are incompatible with the number of patients. And it is interesting because in primary liver cancer, hepatocarcinoma, the endpoint of selection is to avoid recurrence, because recurrence is equal to, I mean, is strictly related to death. By converse, in secondary cancer, as in this case, recurrence is given for granted. We expected recurrence. We know that recurrence are at a very high rate, but we can treat recurrence. And so the endpoint is not to avoid recurrence, but to give some gain in survival with respect to all the other treatment we have, resection, and of course, chemotherapy. So here you have, so there is a lot of interest around this area. And there are several national trials going on in the world. These are from the cancer trial database. I'm going to present some discussion on this Italian experience on behalf of several other authors present today in this meeting. There is no time to go into details, but you can see here there are a lot of variation into the selection criteria of these patients. The Italian COLDS trial is a parallel trial. So we, on purpose, decided not to present a randomized, prospective randomized trial, but instead, the patients are allocated to chemotherapy or to transplant path to strategy from the beginning. So patients in a surgical transplant center are allocated to cold center to transplant, whereas the patient in the, let's say, medically oriented hospitals are selected for this chemotherapy regimen, which is in fact a prospective randomized trial comparing intensified chemotherapy versus standard chemotherapy. Then the patients are followed up and compare. You can see here underneath some of the statistical details. What is important to say is that according to a 1 to 3 comparison, we may have some result after something between 20 and 30 liver transplantation. And so this is a kind of pilot study, but at the same time trying to have some kind of comparison, which is very close to randomization. It's a randomization of center, I would say, rather than treatment. The triplet trial, the trial of chemotherapy, is a prospective phase 3 trial, again, for unresectable, previously untreated, and this is important, RAS and BRAF wild type. So patient, I would say, at good prognosis from the biological standpoint. The primary endpoint is the response rate, and being the survival, the secondary endpoint. But since we are in a surgical context, I will say a few words on what we decide to adopt as a non-resectability of liver metastasis. Now, we have heard from previous esteemed colleague a lot of I would say extremely interesting and important and difficult approach to resectability of liver metastasis. In this trial, we decided that there are two kinds of non-resectable mets. The first one is the, I would say, the technical surgical related judgment of non-resectability, which is reviewed case by a central review board. And a second, more intriguing definition of non-resectability, which is biologically and functional. Now, with respect to technical surgical related non-resectability, I will not go into too many details, or you are all surgeons and you know exactly what we are talking about, and the other experienced surgeons discussed this point before me. But the general aim of the study is to avoid suboptimal resection as an alternative to liver transplant. Although long discussions are in place with respect to the usefulness of R1 resection in presence of effective chemo regimen, a R1 perspective, a perspective that has been part of our practice, is not recommended in this trial as a possible alternative to liver transplantation in a patient otherwise eligible to this option. With respect to biological function, and non-resectability, this applies to procedures that have a high rate of non-preserving enough postoperative liver volume, as we already heard. And in general, we target the prediction of mortality. So once you have a predicted risk of perioperative mortality above 5%, although the patient, it could be a candidate for, let's say, advanced liver resection, he could also be considered for liver transplantation. And in this area, we like to say that we adopted a sort of metro ticket scheme for predicting outcome after resection. You know, there are several studies. We decided this one that above a certain score or tumor burden and a number of tumor nodules and site of, say, of liver metastasis, even if you do a fantastic resection, even if you take out a lot of perfectly resected liver mets, you have a postoperative outcome, which is exactly similar to that of chemotherapy, of advanced chemotherapy, this green curve here. So this is the population in which the liver transplant should be tested, because this is a population that even if is resectable, it could be eligible for liver transplant in order to see if this result can be improved with respect to resection and, of course, to chemotherapy. Just give you a few points on what's going on in the two worlds, from the oncology and the surgical world. And this is a big lesson that we are learning in these days. From when we started the study, and of course, this is a parallel trial, so everyone agrees to share the data between the two arms of the study. The oncology world, the medical oncology world, have a tremendous pace despite the COVID pandemic. And in fact, a week ago, they completed the target population of 450 patients with unresectable liver met to be randomized in the two arms of the chemotherapy study. The same world of medical oncology, despite a lot of attempt from our side and a lot of meeting and discussion, allow us to do and to consider 17 patients for liver transplantation for unresectable liver mets. And I can give you just a few, obviously I have no result to present, but I have some idea, give you some idea on what is going on in Italy. We consider 17 patients. We did 12 liver transplantation. 3 patients are nowadays on the waiting list, and 2 patients dropped out because of progression while waiting. We have already registered 6 recurrences, so half of the patient. There is 1 death for primary non-function after liver transplant, and no patient died because of cancer progression or cancer-related causes. With respect to the Norwegian trial, the SICA-1, SICA-2, you can see that all our patients, the patient transplanted in Italy, are meeting the cutoff of the Oslo score and the FANG score. No patient are above this the cutoff of 2, whereas more than 60%, around 60%, are in the study from Oslo. And also, with respect to previous liver resection, as obvious as we are born as a liver resection surgeon, you can see here that 35% of patients transplanted in Italy had previous resection, sometimes multiple liver resection, which is much higher, is about 1/3 of the patient with respect to the groups in Northern Europe. And the CEA at the diagnosis, it was very high, about 360. The cutoff has to be less than 80 at the time of transplantation. And to conclude, I have 3 final slides on biology and biologically driven activity of surgical in the surgical setting. We have decided to invest in this circulating tumor DNA, what is called ctDNA, which is a tumor-derived fragmented DNA in the bloodstream that is not associated with cells. There is a lot of literature showing us, very recent literature showing us, that there is a clear prognostic impact of ctDNA, negative or positive, or after resection of colorectal cancer, predicting the possibility of recurrence. In fact, there are now trials selecting the patient according to ctDNA after resection to avoid the intensity chemotherapy studies, and also, in fact, to spare patient from chemotherapy. ctDNA monitoring may be extremely useful in the adjuvant setting in order to stratify patients at high versus low risk of recurrence and worth administration of intensified or standardized chemotherapy regimen. So in conclusion, the study going on in Italy, the COLD trial, is not a randomized controlled trial and allows, by the way, a good comparison, a sound comparison of liver transplant versus standard of care of intensified chemotherapy, because this is the alternative that the patient may face. The protocol incorporates a lot of restriction and consider tumor biology, prognostic factor, and also is a kind of original in the definition of non-resectability, which is both technical but also biological and focused on outcome. We have a lot of difficulties. This is a difficult recruitment trial in comparison to what is going on in the medical oncology world for the same patients. And so this is a limitation. Number of liver transplant is too small, is impossible to draw any conclusion, but the result seems similar to original SECA trial with some possible amelioration in the prolongation of time to recurrence, which is, by the way, in most cases resectable and curable. Again, liquid biopsy with the ctDNA should be, in my opinion, implemented to help in the decision of adjuvant therapy, not only in transplant setting, but also in surgical resection. Thank you very much for your attention.
Thank you, Professor Mazzaferro, for your amazing presentation. Now it's time for the discussion. We are opening the discussion. So we had 5 very high-level presentations. So I'm sure we have a lot of things to ask. I see online many discussions, and as I told you, I would like to update you. So we run with constantly more than 200 people online. That it's quite very high-level result. So just to melt the ice, I would like to ask Professor Mazzaferro, thank you for showing us the COLD protocol. And as you know, I had the privilege to enroll one patient. So I see that you put very strict criteria about the non-resectability. So I think that with this work, we will see the worst phase of the liver transplantation in case of colorectal liver metastasis. And the question is, are we doing the same journey that we did with the hepatocellular carcinoma? I mean, at the beginning, we used to transplant the worst patient, then you focused which are the criteria, and then we moved on. So do you think we will do the same journey with the oncology colorectal liver metastasis patient?
Well, I think that we are going by errors. We're trying and errors. So we are trying to find the best possible condition. What is important here is to select the patient which has suboptimal or minimal advantage from advanced resection, and try to find the best biological condition for a significant, I would say, advantage in benefit. So not only overall survival, but advantage with respect to other therapies. I hope we are not, doing the same path of what we did in hepatocellular carcinoma. To understand that the smaller the tumor, the better the result. The number of metastases, the number of tumor, the tumor burden itself is probably not so important. What we need to know is how to predict the liver-only condition. Because if we are able to predict the liver-only condition, we may offer liver transplant to all the patients. But unfortunately, we are not there yet. But the study we are doing with the focus of liver resection and all the patients recurring only in the liver, and we have a lot of these patients, recurring in the liver and then again in the liver and then again and again, and finally progressing in the liver and not in other places. These are the patients that in fact are possible good candidate for liver transplant. And in fact, it is too preliminary, but I like to share this with all the others today. The result seems better in those patients who had multiple previous resection, with those with respect to those who were candidate to transplant, just because of huge diffusion, 150 nodules everywhere, responding to chemotherapy.
Thank you so much. Thank you so much. So now we are going to call in the discussion the discussant. So I saw online Gianmauro Berardi, is a friend and colleague from Rome. Are you there, Gianmauro? So yes. Thank you for joining us, for being with us until now. So I give you the podium for your question.
Thank you, Alessandro. Congratulations, first of all, to you and Benedetto for the high scientific value of the meeting. So I would like to go back to Professor Torsilli's presentation. I have a question for him. So Professor Torsilli, thanks for your presentations. They're always inspiring, and they are a show of amazing surgical skills. Now, I would like to move from the technical point of view and go on the oncological point of view, because, and I would like to make two considerations, because first of all, what is considered as technically upfront resectable in your hands probably is not really shared among most of the HPB surgeons. And the second consideration that I want to make is that we are still in an era where chemotherapy for upfront resectable colorectal liver mets, it's still debated. We have the unfavorable results of the ERTC trial, at least in terms of overall survival. And just recently, last month, the Japanese published in the JCO that adjuvant chemotherapy is not really associated with overall survival for colorectal liver mets. So going to my question for you is, how do you incorporate chemotherapy in the neoadjuvant and in the adjuvant setting with your complex cases? Do you rely on prognostic scores? Is there a risk factor that is the most important for you, or you just give chemotherapy to all patients? Thank you. Are you muted?
Yeah, we hope that Guido has listened to your question, because I don't see it online.
No, I have listened.
Okay.
I didn't push on the microphone, so I was answering, but you couldn't hear. Thank you very much, Mauro, for the nice, the interesting question, provocative question. I may say that about the technical standpoint, really, I don't think that it's just the cultural background. There is no particular technical skill that differentiate this approach from the others. It's a question of mental approach to the organ and to the problem. If it change, you could be able to do exactly the same as anyone has challenged this kind of surgery, has done it, and with profit, essentially for the patient. About the chemo, well, most of our patients are marginal patients. Marginal patient means a patient that are considered unresectable in most of the places where they have been, or most of the time addressed to chemo without even considering the surgical, the surgeon opinion. And then the vast majority now has been submitted to chemo when they come, already submitted to chemo when they come to the outpatient. And generally they are not undergoing chemo in a neoadjuvant setting, but in a, in a treatment setting, the chemo treatment, because considered not resectable. On the other hand, we are now presenting interesting results using a model that has shown that in the fact, since we have a cohort of patients that who, the old cohort was the cohort of patients with multiple bilobar disease who did not undergo chemo. At that time, in the first decade of this millennium, chemo was not so established, and that it was not a scandal to operate upfront a patient like this. And we have seen that if we analyze all our experience, well, the neoadjuvant chemo is not providing better results than the upfront surgery. Up to now, it is culturally and for the patient even difficult to avoid the neoadjuvant chemo for political reason, for the pressure done by the oncologist, and for the approach that we have to keep with them, for in the interest of the patient. Because if we start conflicting with the oncologist, given the fact that the literature does not provide any data in favor of neoadjuvant chemo exactly about the setting we are discussing about, so the multiple bilobar, and for those who were not that setting, there was a failure of neoadjuvant chemo in reality. But despite that, now, incredibly somehow, neoadjuvant chemo is a sort of dogma. So I agree with you. It's a fight that we have to move, fight. I mean, a discussion, a debate. We have to move with the oncological community. The oncological community is leading the management of these patients, despite in the past was not. We have to remind that before 2000, there were no oncologists able to treat any colorectal cancer liver mets. 2000, I mean, 1999, chemo was nothing. 2000, 2005 started for FOLFIRI. Then after,
I take the chance to invite our oncologist, Vincenzo Formica. So do you want to join the conversation? Because I guess you have many issues to comment. So thank you for Guido for being so direct. So Vincenzo, please.
It's a pleasure. Just let me introduce. I'm yes, I'm a medical oncologist. I think I'm a bit isolated here. Maybe just the only one medical oncologist. But first of all, let me congratulate for all the speakers. It was very mind-opening, as Alessandro said, and I feel very comfortable, even though I'm a poor medical oncologist. So after these promises, I'd like, just to make a point that actually treatment is expanding. The systemic treatment for medical oncologists is expanding in a pace, amazing pace, and also the dissection of the disease. So the molecular, stratification of the disease is very increasing in making 5, 6 different subtypes, molecular subtypes of colorectal cancer, and paradoxically, medical oncology is more and more requesting aggressiveness, surgical aggressiveness, because we are more, more optimistic about the outcome, the chemotherapy, the systemic treatment outcome. So my first question is, how do you feel that things and the strategies are changing based on the molecular subtypes? But someone asked, made this question, and so my first question to all of you is how much the strategy is changing depending on the molecular subtype, and also, and this is a specific question for Professor Roberts-Ben, and how much the strategy changed after the liver resection, in the sense that liver first approach has the advantage that you can have a feedback from the histological feedback. On how the pre-treatment, the chemotherapy treatment worked. So how much the strategy changed after the liver resection, after looking at the histology of the liver. So because it's particularly sound for us to have soon a kind of in vivo chemosensitivity test. So to me, the liver first approach would be, the absolute first preferred choice for this reason. So the two questions are these: how much in your experience strategies are changing depending on the molecular subtype, and taking into consideration that we have more, targeted treatment. We've got now immunotherapy for microsatellite unstable patients that are, changing extremely the outcome of this patient. So that's my question, the two questions.
Thank you, Vincenzo. I think Lope-Ben can answer this.
So thank you for the question. And firstly, I think we are far from integrating right now all the genomics and the surgery at the same time. And mainly because we have here surgeons that have the amazing capability of resecting almost everything. And we have in the literature data of resectable or unresectable that is very far from what Guido showed us today. So first, it's difficult to arrive to hard conclusions. But what I do right now to 2021, so I mainly have in KRAS wild type patients. I tend to try to achieve a wider margin, because they are the best patients. In a KRAS mutated patient, the outcome is not based on our margin. So we can go for a more AR1 vascular, more undetachment from the veins. We can be more conservative in the liver, because I think the outcome is not based on the margin. So that's my only reliance in what the molecules we have now.
Very, very interesting reply. Ruben, I think that you want to add something.
Benedetto, can you pick up some questions from the chat or from Spanish colleagues?
I just wanted Ruben to reply because I wanted to say something, and then we can go on to some online question from the audience.
Yes, I wanted I wanted to give a hand to Vincenzo, because I'm a liver surgeon. I do huge surgeries, you know, as Santi said, we can reset almost everything. But for me, and I'm aware what Gianmaro said, and I hope you won't fight against me for what I'm going to say. For me, chemotherapy is not an adjuvant to surgery. For me, surgery is an adjuvant to chemo. That's my personal perspective. My patients with 20, 30 liver mets, they go to chemo. And I saw you a couple of cases, and one of them, after 25 mets, then 12, then 11, all of them removed, all full pathologic response. So, and the patient 2 years later has no disease. So honestly, for me, even though we can resect almost everything, for me, surgery is an adjuvant to chemo. Surgery is the thing we do between chemo intervals. And what you have to be very sure is that you're not going to have a complication, because that from the oncological perspective is a mess. So that's personally that's my personal point of view.
Okay, thank you very much. We can go on with some online.
Sorry, Ruben.
Yes.
Do you think that chemotherapy can be a very good selection tool for surgery?
Absolutely.
You know, from the different perspectives?
Absolutely. 100%.
Especially in this period of time where we're able to low complication very, so this is very also important. So we can make some minimal invasive liver resection without too much complications, and we can assume sometimes that to see the evolution, the oncological evolution after surgery, assuming
absolutely
complications.
yeah.
You know, I don't know if what is your experience, but we have quite a good number of toxicities of chemotherapy who impeded somehow the resection in a proper way. And so we have to find a balance. We have one of the patients listed for liver transplant in Italy. He is listed because this was a patient supposed to be resected in the second time resection after long chemo and very effective chemo. But the surgeon couldn't go, you know, in the resection. There was too much bleeding, too much problems, and so he decided to stop the operation and you know, ask for liver transplant. This is just one of the perspectives that we need to put, you know, in the discussion. With oncologists, not between us. I mean, with the medical oncology world.
We have a very strong relationship with oncologists, and you know, all these patients go to chemo, and we do very short space reevaluations to bring the patient to the optimal moment in which, with the lowest chemo, which has been effective. I think that's definitely the key point.
Agree.
Okay, just maintaining in the same matter, talking about the genetics. There is one question from Marcello Di Martino, it's a surgeon from Naples. He's asking, what's the treatment strategy for a patient with resected bilobral colorectal liver mets and lymph node metastatic disease 9 months after the liver resection? So do you take into account the morphological and biological prognostic marker like the KRAS and BRAF mutation in our decision algorithm? Do you mind to reply, Ruben, if you want? Do you think that for for lymph nodes, strategy may change according to genetics?
That's a tricky one. Actually, I'm not. I remember an analysis that Rene Adam did regarding lymph node metastasis, and I don't know, from my point of view, 9 months after a bilateral resection, the patient has significant lymph nodes. Again, I will bring the patient to chemo and keep the patient on chemo for a while. And probably if the situation is stable after 6 months to 1 year, with wild type, I would probably go lymphadenectomy. It's difficult to answer. I don't know if the rest of the people, what do you think?
Thank you, Ruben. Thank you, Ruben. Can I ask a comment from Eduardo Rosso? Eduardo, are you there?
I'm there. Thank you very much.
Nice to see you.
Very, very nice meeting. I have a question for Sira. So we have seen that biology now is becoming one of the consideration of resectability. Technical reasons for unresectability are very minimal because combining the incredible techniques of Torzini school and others, we can reach by open or by mini-invasive many things. But I think the main point is how to reach the less morbidity and mortality, because now we are in the area of multiple treatment. So as a surgeon, we need to give to our patient the chance to have all the treatment, even in case of recurrence. So my question is, how for multiple bilobar now we can move from open to real mini-invasive? Not just doing 1 or 2 resection in 2 lobes, but how we can move to real liver sparing resection for multiple bilobars. Avoiding majors.
Maybe Ruben, the question was for you.
Yeah.
Not
Thank
easy
you.
question.
No, not
Maybe
easy. Thank you,
It's a
Eduardo.
difficult one, but this is
Well,
the challenge.
actually,
How we
coming
can
from a robotic surgeon
without doing major for very multiple metastases.
Well, actually, thank you, Eduardo. That's the question, definitely. Honestly, for me, and I think I'd like to recall what Luca Aldrighetti said, in a setting of a huge number of liver mets, I would say 10, 12, I don't know, something like that. Doing it by lab, honestly, it's very tricky. It's very tricky, and you have a high risk of missing one or not moving properly. I don't know. And you saw that my case, I did it hybrid. I did a full mobilization. So with a short midline, the patient recovered in 48 hours was the chart. But honestly, Eduardo, I had attempted a lot of them, and for pure parenchymal sparing, minimal invasive, all above 10, 12, 15 liver mets, I think I would not recommend it. I don't know if Luca, maybe he wants to add something.
Well, I agree. I mean, I don't think it's a real problem to choose lap or open. I think the real issue is to achieve the better result for the patient in terms of radical resection and in terms of low morbidity. So that's why I think we have to push the minimal invasive surgery to understand the real limits, meaning that we need to define where is the cut line to go for open approach, because sometimes when you put together the length of surgery, the risk of R1, the chance to convert for complication, and you put all together, the open approach is giving you much safety for the right goals, radicality and low morbidity. So I think this is the time to understand where we can go by lap and by robot. The goal is not to reach 100% resections by minimal invasive approach. That's my opinion.
Thank you, Luca, for this very balanced view. And so I think we will have 10 minutes more, no more than this, but I would like to see the voice of some Spanish colleagues like Patricia Sanchez and Fernando Burdio. Are they there, Benedetto?
Yes, they are there. Let me
Can we
introduce
involve
my
them in the
colleagues.
discussion?
They're in the hospital, from the Hospital del Mar, Barcelona. Fernando, I think that you have a question.
Patricia have to go, so she's not here. But I must congratulate the meeting. I have a couple of questions, one for Ruben and the other for Dr. Aldrighetti. The first one is about the hepatic arterial infusion. You were talking about in your interesting presentation, very well structured. You were talking about this interesting technique. I have not personal experience on that, I have seen this technique in the States when I work. I have seen that there are many toxic effects sometimes, and heterogeneous results. So I would like to ask him if he has personal experience and in your center, and why why does he think in Europe is not so frequently employed this technique? What are the reasons not to do that?
Firstly to Ruben and then
Ruben.
Rodriguetti. Okay.
Yes, afterwards we can ask Professor Rodriguetti.
Well, thank you, Fernando. Actually, I don't have experience in our center. Is not implemented the hepatic artery infusion, so I can't give you a very good answer about this. And according to literature, it seems that in a truly unresectable setting, there seems to be a survival advantage, and also it seems that some of patients, about 10%, maybe downstage to a resectable situation. I don't know that maybe if Gianmauro has been there in Memoria for a while, maybe he can give us. He has been really involved in this setting. So
Thank you. I will be very brief. Yeah, I will be very brief on this. We have to remember that it's different. So at Memorial Sloan Kettering, they use hepatic arterial infusion, but the drug is different because they use FDR, which is fluoxetine, which you can give 200 times more dose than FOLFOXIRI, and this is not approved here in Europe. So there are a few trials in Europe. I think in the Netherlands, there's one running, which use not the FDR, which is not approved here. So that's why we're not really using hepatic arterial infusion here in Europe as they use in the US, in which they show amazing result. I can tell you, I saw patients with unresectable lesions, completely unresectable, having amazing response to that.
Okay, thank you. And the other question for Professor Rodriguetti. Thank you for sharing your experience. Many of us have been with you, and we have learning with you your wonderful experience, especially in laparoscopic approach to the liver. You have been talking also about the two teams approach in the colorectal meds and colorectal surgery, and also the beds. My question is about the logistics. How to set all that? It's not quite easy. Sometimes not only for the to arrange all the teams. You have a lot of experience. About 80%. It's around 80% of your resections. About almost 20% of your resections in the liver are combined. The concrete question is how to deal with these cases when the field is completely different for the colorectal surgery and also for the hepatic surgery. For example, for posterior segments, the position of the trocars are not useful at all for the resection of the colorectal tumor, and sometimes I find quite easy to perform all these cases in 2 times, even if in one case it can be approachable.
Thanks. Well, I think it's it depends a lot on which kind of attitude is from the colorectal surgeons, because I can tell you, if you define a synchronous case together and you go together at the beginning of surgery in the operating room, choosing the position of the trocars, I think it's possible to find a pretty good compromise. What we usually do is that we always start with the colorectal resection. We never start with the liver, regardless, because as you saw, we published a paper where even when the liver is operated by open, there is an advantage to operate the colon by lap, because it reduced the overall complications. And obviously, the risk of conversion is higher for liver surgery than for colorectal surgery. So that's why we always start with the colorectal resection, which has a low rate of conversion. And then we work on the liver, trying to use most of the trocas they used also for the liver. Most of the time that's feasible. So I think it's all about how much your colorectal surgeon is prompted to work together with you. We discussed together all the cases. So I think, as I said, is a matter more of type of relationship than a real technical issue.
Okay.
Thank you, Luca.
Thank
So
you.
I see online Carlo Esposito. Can you please join us, Carlo?
Hello. Hello, Alessandro.
Ciao. Thank you.
Thank you for inviting me, and thank you for your wonderful webinar.
Welcome.
I wanted to ask, to make a comment and ask a question to Dr. Santiago Lopez-Ben. I liked very much your presentation on the treatment strategy for synchronous liver metastasis and on the liver first approach. I want to comment on the treatment strategy proposed by the last paper published by the Liver Met Survey, because I think that the magnitude of the survival benefit given from by the liver first approach is slightly underestimated, in the sense that maybe if we study the efficacy of this approach on an intention to treat basis, we may find that this approach has a higher survival benefit, because maybe sometimes when we decide to operate on the colon first and on metastasis later, we may lose some patients, or we may find out that we have to make bigger operations on the liver, while making the liver first approach, we may operate more on the liver. We may achieve more radical resections. So this is my first side of the coin, and the second side of the coin is, when do you think that the liver first approach has to be avoided? Thus, when we should always do the colon first approach? Thank you.
Thank you, Carlo, for this question. I try to answer you. I think you're right. One of the advantages of liver first approach, if applied in the correct setting, that I think is the patient with a high liver tumor burden, is that you can avoid unnecessary surgeries, because all the patients that you resect the colon, and after the liver, the colon is resected. And all these patients with multiple and bilateral lesions that recur in the very, very early setting, you avoid the colorectal surgery. So you are. This is one of the reasons. I think all the patients in liver met survey are patients that are resected, or at least taken to the theater with the will of resecting. So it's not the lost patients are not there. So you can, I totally agree with you. You can underestimate the benefits of liver first, but and surgery is very, very, very difficult to have a huge I may say to have how can I say, to have a solid conclusions because of a variable of all the patients. But I totally agree with all your points regarding this situation. On the other side, just a small point for the second question is, you have to avoid to make liver first in a complicated patient. And 3 weeks ago, I operate a patient that was with a rectal cancer, and after the surgery that we performed the liver, during the postoperative time, the prosthesis that was inserted in the colon was obstructed, and we have to replace another stent in order to avoid the problems of an occlusion in the early postoperative sitting after liver surgery. So if the primary are huge, go for the primary.
Thank you so much, Santiago. That's quite interesting conversation. I guess it's very interesting. And if you all agree, we can just conclude with just 2 more questions. We conclude with the pink color. So I would ask Patricia Sanchez and Laura Tarisciotti if they want to. I would like to ask just very quick question and answers, so we can conclude with the pink color.
Okay, thanks, Alessandro. I've got a quick question for Professor Torselli. In his experience for parenchyma sparing liver resection, do you combine also the use of ablation during the surgery?
Quite rarely. Just in the event that we found a new lesion, deep, tiny, and deep, of course, that if the lesion is discovered intraoperatively, normally is a tiny lesion, and deep into the remnant parenchyma, for which after the resection, the removal of the, even limited resection for achieving the clearance of that tiny lesion would impair the balance of the future liver remnant. In this condition, we would, of course, accept the ablation. I mean, the crucial point, because if you have a very small lesion, and from that target, you have to remove a high percent, a relatively high percentage of liver, of normal liver tissue, this would not be anymore a parenchyma sparing resection. Then in this sense, you should avoid to do this kind of approach. I mean, the secret of parenchyma sparing is always to approach the tumor from the shortest way of dissection. Then you have to, even if you mobilize completely the organ to do that, but you have always to maximize the ratio between the tumor burden that you remove and the parenchyma that you sacrifice. In this sense, if you have a very small lesion deep into the remnant liver, in terms of parenchyma sparing, paradoxically, is a paradox like parenchyma sparing major hepatectomy. It becomes a major minor resection.
Thank you, Guido. Thank you so much. So, Patricia?
Because Patricia is not here, I wanted to substitute the question from our online question from Eva Montalva to Professor Mazzaferro. A very short question with a very short reply. So, about the missing metastases, if they are considered when the decision of resectability is taken in the central tumor board, Professor Mazzaferro. Would you consider this missing metastasis in the decision algorithm for transplants?
Missing metastases are always a problem, but when we decided that we have to, there are many studies that tells us that when you take out the missing metastasis and you find it, some part of vital tissue is still there. So when we decided the burden of disease at the time of transplant, we counted the missing metastasis as I would say, less than 1 centimeter lesion.
Okay, thank you very much. Alessandro, you want to conclude this?
Yeah, I'm amazed, and I want to thank you all, because all the speakers, they brought the level so high, and I'm amazed, and I learned so much from today. So I want to congratulate and thank you all for being with us. I thank you, again, all the participants online, that have been so many. I thank you, Benedetto, for the inspiration and for the good food in Barcelona we had together. So I thank you again, Baxter, for their support, and so they made us the chance to organize everything. So I give you the appointment to the next 2 meetings, so one in February, one in April. So stay tuned, and we will back soon. Thank you all.
Thank to all of you.
Bye-bye.
Bye-bye.
Thank you. Thank you. Thank you all.